I see more people coming in. Good morning, good afternoon, good evening, depending on where you're joining us from. I'm just going to give it one more minute to let a few more folks join, and then we will get started. All right, we're right at 8:34. So I'm going to get started. People will continue to join as they, wake up if they're over here or over on the West Coast, or just join when they're available. But again, thank you all for joining our July monthly webinar. Just going to go over what we plan to go over today, and then we will get into the meat of things. So for those of you who have joined one of our webinars previously or have watched one of our recordings previously, this agenda will look pretty familiar, just with some new faces. So I will go ahead and at this point introduce the people who will be speaking later. So we have Andrea Leiner. Am I saying your last name correctly, Andrea?
Leiner.
Leiner, thank you for correcting me. And then Adam Ackerman here. Andrea is with Global Response Medicine, one of the NGOs we work with, and Adam recently deployed to Ukraine in partnership with her organization. So we're going to hear from them later. First, I'll go through a brief overview of H1 Connect for those of you who are like newer or might not be aware of what H1 Connect is. After I have a full conversation with Andrea and Adam, we'll have a Q&A. You can keep these questions coming as the conversation progresses via the Q&A function in Zoom. I will try to get all of the questions answered either live over the call or in the chat to you privately. So with that, I will get started with an overview of H1 Connect. See if my slide will move. Cool. So again, for those who are unfamiliar, newer, I just want to give you a little background before we get into the meat of this conversation so you have the information you need. So H1 is made up of two sides, so to speak, and they're both illustrated by this slide here. The right side is the reason we're here today, and that is H1 Connect, wherein we connect global healthcare professionals like yourselves to training, resources, and content, as well as opportunities to volunteer with NGOs we work with, like Global Response Medicine. Our current network of global healthcare providers is made up of now 5,600 clinicians around the world and is growing. The other side of H1's business, so over on the left, connects doctors with industry to support their research and clinical trial work, and involves maintaining a database of over 10 million healthcare professionals. So both sides of this business work together in furtherance of H1's mission to connect the world to the right doctors. Over on the left, so that side that supports like pharma and life sciences, is how we're able to fund our work with NGOs over on the right. Now, as H1 continues to grow, we have a vision of like ultimately being able to leverage our existing relationships with pharma and life sciences companies to connect global healthcare professionals like yourselves with opportunities to work on research and clinical trials. Right now, at this like early stage of H1 Connect, we are focused on humanitarian response. So since we started doing this work in October 2023, we've learned about the World Health Organization's Emergency Medical Team, or EMT program. So as part of that program, the WHO pushes NGOs to maintain large reserve rosters of healthcare professionals who are vetted, engaged, trained, and ready to go before a conflict or disaster strikes and they may be needed. So our goal is to do a lot of the heavy lifting involved with maintaining these rosters on behalf of NGOs, and to build a global ready reserve roster that they can call upon when they need to deploy an EMT. So this benefits the doctors in our network as well. So by joining H1 Connect, ultimately, you'll be considered pre-vetted by NGOs we work with when there is an opportunity. You'll have access to all of those opportunities in one place, as well as trainings and resources recommended by the NGOs we work with, as well as our medical advisors at the Harvard Humanitarian Institute. I've got one more slide and then I'll get to the really good stuff, the conversation with Adam and Andrea here. But one last slide. I just want to take a moment to highlight the new and improved H1 Connect website. So we've essentially made the site easier to navigate and more intuitive. So you're able to take advantage of the opportunities, resources, and ways to get involved in the network we make available to you there. So all that which I just described. I will drop the link to this in the chat as we get into the conversation. But for now, we're going to turn to Andrea and Dr. Ackerman. So again, just to call out Q&A guidelines before we get into the meat of the conversation. And again, feel free to post them as questions come up. If you have anything specific to like your application status, or do you need this type of doctor, anything that's specific to you, reach out to the volunteer at h1.co and we can handle those like individual questions offline. All right, so I'm gonna actually stop sharing my screen so that we can see Andrea and Adam's faces here. Great. So thank you both for joining today. I'll start with some introductions and I'll start with Andrea. So to start, can you introduce yourself and Global Response Medicine? How did the organization come to be? How did you get involved? All that good stuff.
Okay, so thank you very much, Katie, for hosting this, and thanks, Dr. Ackerman, for joining us. My name is Andrea Leiner, and my clinical background is as a nurse practitioner in emergency medicine. I'm licensed in family practice and acute care. And I found Global Response Medicine through a podcast. I was listening to MCRIT one day, for anybody who listens to emergency medicine or critical care podcasts, and I heard the executive director at the time on talking about their work in Iraq in 2017. So Global Response Medicine, GRM, was founded by military veterans in the US who had seen firsthand the toll that conflict takes on civilians and wanted to do something about that after they rotated out of service. So the first mission was in Iraq, in Mosul, during the retake of the city from ISIS, and they set up trauma stabilization points within the WHO network, working with other NGOs and INGOs to deliver stabilizing care and transfer patients back to field hospitals and other hospitals outside of the conflict area. From there, GRM did work in Yemen, in Bangladesh, worked in Hurricane Dorian in the Bahamas, and that's about when I joined GRM in 2019. In 2019, our executive director at the time got a call that there was a pretty terrible situation going on at the US-Mexican border. So we responded with a small team, and we ended up working on the border on the Mexican side for about 5 years, doing clinics in a lot of the higher risk areas, and operated those about 24/7. And so what we try to do is we try to combine pre-hospital medicine with academic emergency medicine, and also lessons from field medicine and austere medicine in the tactical sense, and apply those to high-risk areas. So high-risk, low-resource response is what we focus on. We've developed 2 tracks. We provide direct care. We're one of the WHO emergency medical teams. We respond as a specialty care team when an emergency happens. And we also work on capacity enhancing projects. We work hand in hand with our local partners to help them deliver the medical care that they need to in the context that they're facing. So we do a lot of training as well. Our work has led us to many different countries. We've been in Ukraine since the first week of the war, first providing a surgical care program in the Donetsk area, embedded with Ukrainian physicians working there, providing critical care transport, as well as over the last year and a half, a training program anchored in Dnipro, Kharkiv, and at the burn hospitals, increasing access to evidence-based care in trauma surgery, emergency medicine, and acute burn care. And currently, emergency medicine and trauma surgery are not fully recognized or taught disciplines in Ukraine. So it was very much a pilot project with WHO and the Ministry of Health to test what could work to build these proficiency pathways and the professional relationships needed to develop those disciplines. We also have continued our work in Iraq, and we participated in putting on an emergency medicine fellowship in northern Iraq over the last year. We've worked with Butterfly a lot on ultrasound training and using that as both a diagnostic and procedural tool in low resource environments. And we are currently supporting in Gaza as well. So that is a little bit about us. We are a small organization, but we have incredible supporters, and working with a group like H1 has allowed us to keep our supporters engaged, allow them to find other opportunities when we are not currently deployed, and to pull in incredible folks like Dr. Ackerman, who we met on our last Ukraine deployment through H1.
Thank you so much, Andrea. And we're so glad to be able to support an organization like yours. Now, I know the answer to my next question will vary slightly based on like what type of team it is, what region you're operating in. But in general, can you explain GRM's current deployment model? And by that, like, what is the general makeup of your teams? We've heard a little bit about like what general clinical focuses your teams have. What organizations do you partner with to get your teams on the ground? And yeah, any other additional details of that nature?
Sure. We're often working in pretty high-risk areas, so we take safety really seriously, and we lean into that. The point is for everybody to come home. We're bringing folks together who are giving us their time, their talent, and their trust, and so we try to handle that as responsibly as possible in these more dynamic areas. So we work in a small response model. We have a team lead who's responsible for safety, for operations, and for a 360 view. And they're usually pretty highly trained paramedics and critical care paramedics, so they can also deliver emergency medical care as needed. From there, we round out the team with whatever discipline is needed. We always have an emergency medicine component, since emergency medicine can flex to anything that's needed and kind of be that jack of all trades on the ground. And then it depends on the request. Sometimes it's for people to do training. Sometimes it's a very specific request, like a maxillofacial surgeon that is needed at this time for these next 2 weeks in this area. So like you said, every situation is different, but we stay anchored in that team lead position, providing an emergency medicine component and being really flexible for the environment.
Awesome. Thank you so much. So as you know, we're joined by Dr. Ackerman today, who you know well, and recently deployed to Ukraine with Global Response Medicine. So to set the stage before I direct some questions to him, can you talk a little bit more about the work you've been undertaking in Ukraine specifically since the beginning of the war, what that looks like now, the different types of work you're doing there, et cetera?
Sure. So the first year of the war was focused heavily on direct care, and providing that direct care. We had 24/7 surgical services, like I said, out in the East for about 5 months, as well as medevac services. But really what was needed in the beginning as well was training. So we did trauma care training for everybody at every level, at every stop we made along the way to get to our posts and back. In the second year, the government wanted to pivot more to enhancing the local capacity. So we partnered with WHO and Ministry of Health to take on the development of emergency medicine, trauma surgery, and working with the 3 burn hospitals in acute burn care. And it was really a focus on connecting how these 3 disciplines work together, which were not fully developed disciplines and also not kind of sewn together in a holistic chain of care. So over the last year and a half, we've piloted that, anchoring it in several hospitals, developing concepts and protocols in those 3 disciplines, working at the bedside with them. There's also been rotations to the United States. They've rotated to Mass General Hospital, Boston Medical Center, University of Chicago. We had folks at Hartford University, University of Florida, Temple University, and Harborview out on the West Coast. So it was a program that built from didactic and bedside training all the way through a 2-week observership at a U.S. trauma center, and then bringing those lessons back to combine what works in the Ukraine context. It's not about transplanting American medicine to Ukraine. It's about finding the threads that work to build the Ukrainian acute care system. So Dr. Ackerman was part of the last rotation we had to Ukraine, where we were running advanced surgical skills and for exposure to trauma surgical courses on working with pigs, and it was part of the pathway to explore proficiency methods for surgeons who are being retasked as trauma surgeons in Ukraine. So I will leave it with Dr. Ackerman there.
Yes, so I will get back to more questions to you with more questions. But for now, hi, Dr. Ackerman. Good morning, and thank you again for joining. So can you also start by introducing yourself and speaking a little bit more about your clinical background broadly?
Yeah, of course. Well, good morning, Katie. It's a pleasure to be here with you and Andrea today. My name's Adam Ackerman. I am a assistant professor of surgery at the University of Vermont, where I work as a trauma surgeon as well. My background, I trained in general surgery up in Maine, and then went on to do a trauma and critical care fellowship in Detroit. So a pretty active fellowship there. And from there, I spent a couple years at Mass General in Boston, and then found my way up to Vermont.
Awesome. So outside of your clinical background, and I know they will go hand in hand, but can you talk a little bit more about your previous deployment experience? So have you deployed previously? What has that looked like? Have you worked with NGOs in the past? Just speak a little bit more to that type of experience.
Yeah, of course. My first experience was actually in medical school. My first year, I had a really close friend who was working with a clinic in Guatemala and asked if I would come. And we talked about, what sort of project could we do that summer while we were there. And the thing that they didn't have was a laboratory. So they were doing clinical care without any sort of laboratory capabilities. I had some research background in laboratory medicine, and we decided to build a lab. And it worked really well. And we kind of took that show on the road and ended up deploying to a bunch of different locations, obviously Guatemala, Haiti, Zimbabwe, a few different places. But that was just, two friends kind of figuring it out on our own, which was, a far cry from H1 and GRM's ability to do global work. Additionally, I've done some surgical work, mostly in Zimbabwe and Rwanda, and those have both been very rewarding opportunities.
Wonderful. We hear so many people earlier in their career saying like, how do I get involved with this type of work? So it's nice to hear how you began at the beginning. Began at the onset of your career. Now, as we've mentioned, you recently deployed to Ukraine with GRM. Can you describe how you got connected to GRM and then your experience with them generally in Ukraine?
Yeah, I was sitting at work and I got an email in my inbox from H1. I hadn't heard of H1 before. I was talking about an opportunity to volunteer in Ukraine. I went around, asked a few of my partners, "Have you heard of these guys?" And we had, and then did a little research, and it seemed like what H1 was doing was very cool and interesting. So I just reached out by email, and H1 connected me with GRM. So it was a very easy process.
We're so happy to hear that. And then, so once that, initial introduction was made, what was your experience directly prior, like planning to deploy, and then on the ground in Ukraine itself with GRM?
Yeah, I have to say it was a really good experience for me from day one. GRM was very responsive, easy to communicate with. It was, having gone abroad previously and doing some work on my own, it was really nice to have professionals doing the planning and the logistics behind the scene. I've never really had that before, and it was fantastic because I could really focus on what I was there for, which was to teach surgical skills. I didn't have to worry about my safety. I didn't have to worry about transportation. I felt like I was really in good hands with GRM. It kind of leads me to talk about the ground team. They were great. The team lead was fantastic. Again, I think when you go to those places, you always have a little voice in the back of your head reminding you that you're in a dangerous place, that, things could happen. But I just really felt like the entire time things were under control. My safety was, a focus of the team. And all that stuff just goes to really help provide a good experience so I can focus on, the surgical work. And I really appreciate that.
That's so great to hear. And what we've heard about GRM generally is that they are wonderful partners when you're doing that type of work on the ground. I'll turn to Andrea for a moment. So Andrea, we've heard from you and your colleagues at GRM just over the course of our regular conversations that Dr. Ackerman and the rest of that team he deployed with were incredibly successful. We've heard nothing but glowing reviews. And I'm not just saying that because Adam's on the call. So how do you and GRM define a successful deployment, specifically like this type of deployment, and what made this one so successful?
So first, I'll just start and say probably the one of the biggest hurdles for NGOs, especially small NGOs, but I don't think it's unique to small NGOs, is the selection process for your volunteers that you're deploying. You are so dependent on them fitting into the team, to the situation, being excellent in their skills, whether that's teaching or direct care. And it's often in really stressful environments where the travel getting there is really stressful. I mean, just to go to Ukraine, you have to fly to Poland. There's overnight trains involved and other trains to get to your location. And you usually haven't slept in a couple of days, and then you're slotting right into your duties. So selection and our volunteer roster is what we talk about the most between us at different NGOs of just how to put the best people, how to find the best people, how to put them in the place that you need, and usually do it in a really quick turnaround. Some of these things like training opportunities, you could plan a little ahead of time, but when it comes to an emergency, no. And when you think about the 5 months of 24/7 surgical care that we provided, how to staff surgeons, how to get time off for a minimum of 2 to 3 weeks, how to get them into country, how to staff and keep that up and make sure they fit in with the team is really difficult. So one of the things that we've really appreciated, but we're a little bit nervous about in the beginning, is opening it up to a different organization, working with H1, having an unknown quantity come in and work with us that was outside of the regular rotation. And it turned out to be an incredible experience. All three surgeons who were in with our senior medical director, my attending physician in the ER, they were incredible. And we had worked with one of them before, but not Dr. Ackerman, and his other partner came in. So having H1 participate in the selection process with us, get the final selects over to Maggie, our volunteer coordinator, who's also just really incredible and awesome, made the process a lot easier. And when it went so well, and we got such good feedback, both qualitative and quantitative feedback on the class and how it was received and the impact that it made for our Ukrainian colleagues. It felt really good. And so we're excited to continue this partnership and meet folks like Dr. Ackerman through it.
Well, we're certainly glad to hear that, as that's, the whole mission of what we're trying to do is to make, the difficult work you're already undertaking just slightly easier and more turnkey. Speaking of which, we know global response medicine is now focusing on deploying into Gaza, which, comes with it a whole host of additional considerations, security concerns, et cetera. Where does that effort currently stand? What types of teams are you putting together? And then what are those particular challenges with working in a place like Gaza right now?
So every situation is challenging, but I think Gaza is probably the most complex place that any of us have worked. And it's for many different reasons. It's the logistics, it's the security, it's the instability. It's that there's no static front line. It's all around you. So there are so many considerations getting supplies in. Even if you can get the surgeon to where they need to be, there's no guarantee that there's going to be supplies for them to operate. So there are so many factors when weighing risk to benefit in the situation of Gaza. Further complicating it is the entry and exit. Right now, there are very limited seats available to get in and out, and that is negotiated at the UN level. That is not something any of us as NGOs have any control over, and we're all kind of along for the ride, quite literally, when it comes to entry and exit. So we are one of 8 specialty care teams working with Heal Palestine and the Kuwaiti Field Hospital. We took the approach in Gaza. We didn't have a footprint before the war. And I think it's really important to have some self-awareness of where you can push in and be really helpful, and where sometimes that intention to help can be extra noise. So we decided to support other organizations who had a longer footprint in Gaza. We worked a little bit with Med Global in February and April, and then partnered up with Heal Palestine and the Kuwaiti Field Hospital. What that looks like now, we've had 2 rotations in, and then securing consistent rotation has been a challenge for everybody. So it was just negotiated at the UN level of how that entry and exit is going to go. And we will start with just a few seats in mid-August on a month-on, month-off rotation. Further complicating Gaza is that it's a minimum of 4 weeks. You can't get out before 4 weeks, and you could be delayed on either side, whether that's entry or exit, by a week or 2, which makes it really difficult to staff. So very small seats allowed in for every NGO, and then the flexibility of almost 6 weeks for anybody responding.
Yep, that's in line with what we've heard from other NGOs as well. I'm sure we'll get plenty of questions about that once we bring the Q&A questions in. Dr. Ackerman, one last question for you before we turn to questions from the attendees. So as someone with substantial international experience, you're speaking to a lot of people who have joined who are quite interested in that experience in those opportunities. So generally, what advice can you give clinicians who are interested in, global health and humanitarian aid work?
Yeah, I think the most important thing I've learned is just to keep an open mind, and to really know that the people that you meet on the ground in the various locations where you go, they are actually they're the real experts, because they know the system, they know the supply lines, they know how they can get what they need to take care of their population. And it sounds a little bit cliche, but I always, if I kind of approach these deployments with that mindset, I always leave kind of feeling like I got more than I gave. I learned a lot, which is really it's really rewarding. So it's not just that I'm doing something good. I'm really getting a lot back. So that would be my biggest advice.
Well, thank you so much. Now we've got plenty of questions.
Can I piggyback on that really quick? I think Dr. Ackerman picks up on a great point, because there's a lot of dialogue at the higher levels and the theoretical levels of global health, of whether it's bi-directional learning, capacity building, those kind of things. And I think what it's important to remember is you have local expertise, you have international expertise, and those overlap for a novel context that's going on, whatever emergency it is. Nobody, whether responding locally or internationally, it knows that unique context that's happening. So like Dr. Ackerman said, we're all there to work together to find solutions for that unique context. And it's really incredible. I think one of the silver linings of COVID was the collaboration between scientists, medical professionals, and private industry to come up with novel solutions. And I think a lot of humanitarian response can have that same feel if you go into it with humility and openness.
Yeah, no, thank you for adding that. I think we, as we've learned more about this space ourselves, our understanding is the EMT program and the World Health Organization's protocols were really put in place to make sure that people weren't just coming into a situation and trying to impose work upon an area. It's about partnering with people who are familiar with that context and experts in the space, to make sure that the people in that area are safe and healthy. All right. So I have one question from the chat. I guess, Andrea, I'll direct this to you. Adam, if you want to chime in based on your experience in Ukraine with GRM, feel free. But this comes from John, who's an ER doctor in both urban and rural areas in Canada. And he is asking, can the H1 staff address in general the danger mitigation taken in places like Ukraine? So I'll start with, a comment that H1 is not responsible for any of that safety mitigation. We are certainly not qualified to do so, but organizations that we work with, who you would deploy with through H1 Connect, like Global Response Medicine, are. So then, Andrea, I'll let you speak to the rest of the question.
So it's a good question, and it's one that everybody who's thinking of deploying should be asking and digging into, and that's including myself before I go to certain areas. Is this an area I should be going to? Is this more appropriate for other people? And what are the pieces that are needed to maximize the potential to come home? Because that's all we're doing. None of us have force fields. None of us could deflect a random missile strike or anything like that. And I think, as we've seen in Gaza, there have been killings of NGO workers and international NGO workers, which is really it's disturbing that it's continuing to rise. In 2024, I was just on a health cluster call in Ukraine, and I think the attacks on healthcare facilities have already exceeded the 2023 numbers in Ukraine. So mitigation steps, it's surprisingly, one of the biggest and scariest factors in Ukraine and risk factors in Ukraine is the driving on the roads, not wearing seatbelts, like those kind of things that are very commonplace can sometimes be your biggest risk factor. But we really lean into our team leads and our folks who have a lot of professional experience in safety and security to evaluate what the risk is, evaluate what mitigating steps can be taken, and then decide, does the benefit meet the risk that is necessary to do that. So I wish there was a better answer, but really do your due diligence on anybody you're thinking to deploy with, because safety is not always something that NGOs do well. It's a lot of well-meaning people who don't have a safety and security background, and there are certain organizations that do it much better than others. So just be careful.
Yeah, and that's something H1 takes into consideration as well when deciding what type of organizations to work with and all of that. Other questions, and Miles, if you're getting any that you'd like to call out, let me know. I am seeing a question about, and we get this a lot, different clinical designations and those people that are important to you on teams. So I know we obviously talk a lot about like physicians, surgeons, emergency medicine doctors. What about nurses, EMTs, NPs, those types of clinicians? Are those typically a part of your teams? It could depend on the deployment itself, Andrea, but feel free to speak to that.
Yes, 100%. Now, we have to recognize local laws in certain countries and their recognition of, say, advanced practice providers, or what scope paramedics have and that kind of stuff. So usually what we do is negotiate on the front end with the government of what licensure they are comfortable with, and then what procedures we need to follow. We have a senior medical director at our organization. Any folks like nurses, paramedics worked under his license. So there's multiple layers. We work at the country level of what's allowed, and then we structure it in the same way as in the US, with supervision and protocols that you would have working as a non-physician in those areas.
Thank you so much. Adam, can you speak to the makeup of the team you worked with in Ukraine, just to give color to Andrea's answer there?
Yeah, absolutely. So the team was pretty small, which was actually kind of nice to work with a small team. It was myself, two other surgeons. There was Scott, who I think Andrea knows, and also our security team lead. So it was just a small team. I thought that H1 and GRM had done a really great job selecting people. I was really impressed with the two other surgeons that were chosen to go. Just extremely well trained, a really broad experience. So that was the team makeup.
Dr. Ackerman, can I ask you a question? Because something I found working with surgeons is as surgery gets more specialized, particularly in a country like the US, it can be a detriment to somebody who wants to respond as a surgeon or even a highly specialized physician in some of these areas because you have to be more of a jack of all trades. So that's something discussion I've had with our surgeons. What kind of experience or proficiency would you recommend for, in particular, a surgeon going to these areas?
Yeah, from talking to a lot of the Ukrainian surgeons and trainees, the thing that they were most interested in was the idea, the concept of trauma surgery as a specialty. Um, but that being said, if you're trained, especially in the US, I know there's a fairly large international group on this chat, but if you're trained in the US, your experience in general surgery is broad enough to instruct and to also practice in these environments. We're lucky enough, here to get a lot of trauma experience. I think, like I said before, I think if you are broadly trained, going to one of these locations with an open mind, using your skills and then augmenting those skills with local knowledge, I think a lot of people can be really useful and really successful in some of these austere environments.
I agree. I was once doing a panel with somebody from ICRC, and they had responded to a conflict area, and their surgeons, I think, had almost, or the cases that came in were almost 40% maternal health cases. So, here were a bunch of trauma surgeons and having to manage, complex pregnancies and that kind of stuff. So that was a startling statistic.
Yeah, yeah. I think you adapt very quickly.
Well, Katie, looks like we have a hand raised, so
Thank you,
me,
Miles. But thank you for that question, Andrea. That was great.
yeah, thank you. All right, so let's Ridwan Dalil, I'm going to allow you to talk. So go ahead and unmute yourself and ask your question. Ridwan, are you able to unmute yourself? There we go.
Hello?
Hi,
Yep,
yeah, we can hear
hear
you.
you.
Hello?
Yeah, can you hear us?
Yeah, yes, yes. Can I introduce you?
You say that again?
Can I introduce myself?
Please.
Hello?
Yeah, please.
Just,
Yeah.
yes,
Yeah.
just I'm Red One. Just I'm Red One from Ethiopia. And I'm a nurse, I'm a medical nurse, and it's 40-year experiences. And I have an experience in the national and international government, and I have an experience in deployment in the outbreak area by UKMed and the Africa CDC during the time of Ebola outbreak and during the time of cholera outbreak in Malawi, and the time of the cyclone attack in Malawi by UKMed, and I deployed in West Africa, in Sierra Leone, during the Ebola outbreak. So I have a good experience in international deployment in crisis and hectic area. So that's all about me.
Yeah, I had a little bit of a hard time hearing you, Ridwan. Andrea or Adam, were you able to catch that?
I was.
Okay,
Dr.
great.
Ridwan was just introducing himself and sharing a little bit about his experience. So thank you for that. I hope you're registered in the H1 system so that organizations like ours can tap you for deployments as needed, because it sounds like you have a lot of really incredible experience that would make our responses better.
Thank you, Andrea, and thank you, Ridwan. A question related to that, Andrea. So we've heard a lot about the doctors that you bring onto your teams internationally to come into a conflict zone or an area where there's a disaster, et cetera. What type of folks do you work with locally? And do you recruit any of those people yourself, or are you working through like local health ministries, hospitals, et cetera?
So I think that's different in different concepts. For instance, in Mexico, when we worked for 5 years, there was a large professional class of people who were refugees and asylum seekers themselves. So we had a lot of doctors from Cuba, we had a pharmacist from Venezuela and others. So we worked with the local health authorities to understand the guidelines, verify their licenses, and then they worked in our clinics, and they served as the main care force for us down there. That was augmented by U.S. volunteers. So that was a great collaboration. In Ukraine, we're constantly working with our Ukrainian colleagues in partnership, and in other places, the same thing. So yes, we are constantly recruiting and working within the systems that already exist. It's a better model. It's easier on logistics, and that's what we try to do. I also wanted to respond to something I saw in the chat by Emiliana asking about a mentor, and I'm going to throw that back to H1 because I think as you guys develop this system, that could be a pretty cool feature to connect folks as mentors and mentees within the system. So throwing that back to you guys.
Yeah, Emiliana, I'm seeing your question. Thank you for flagging it, Andrea. So we don't currently have that in place. However, we have all of the, ingredients, so to speak, to put that in place, wherein we have a lot of qualified doctors, some of whom may be retired or not able to deploy actively, but still have a lot of expertise and knowledge in specifically the humanitarian aid and global health deployment space. So I think it's a great opportunity for us. And that's something Miles and I can take offline. As we mentioned, this effort started in October 2023, so still quite new, and it's really informed by what the people in our network need and what the NGOs we work with recommend. So I think we can take that back, Miles.
Yeah, and the only thing I'll add to that is, so we don't have a formal mechanism on the platform to find and connect with mentors, but we do have our WhatsApp community of more than 1,000 medical professionals around the world as a more informal way to get to know each other. So I'll drop the link to the WhatsApp group in the chat, and I encourage as many people as possible to join.
And I think the other questions I think fall under a broader category of how to be visible, how to deploy with an NGO, what the process is like. So I can just address those really quickly. Yes, other disciplines like pharmacists can join the organization if it is a needed specialty. Pharmacy can get a little tricky, as can anesthesiology, because a lot of times the medications are called by different names in different countries. They're at different dosages. Or concentrations, and the health authorities locally are usually a little bit hesitant to release that kind of control with somebody who's unfamiliar with the system. But it still can happen in different ways. Junior practitioners, I'm assuming that means maybe an intern or a resident. We have had residents rotate with us before. They rotate with their attending physician. That's It's not something that we take on. These spaces aren't spaces to learn in. These spaces are to bring something, but we have had universities rotate, particularly in Mexico, with an attending physician and several residents to participate. So that's gone well for us. Enrolling medical teams from Africa and also how are volunteers chosen? I think the best thing to do, we are open to volunteers from all over the world. I think the best thing to do is to stay connected with H1. That's really opening up different pools of volunteers for us and for other organizations. And then it's just really deployment specific. So how it works for us is we are not Doctors Without Borders or MSF. We do not have thousands of people deployed all over the world at any particular time. We have very small kind of targeted missions that meet a specific need. So our deployment roster at any one time is much smaller than I think other organizations. But usually how it works is a project comes up, there's a specific ask for things, whether that's on the training or direct medical care side. We get those requests from governments, we get those requests from the WHO, and then we process them through. So Maggie, our volunteer coordinator, will work with myself and one of the project leads on the specific project to develop what profile we're looking for. She communicates that through H1 and also through our own newsletter and email system. It goes out simultaneously. And then she'll get back the responses. She'll call through all of them, see immediately flag who's appropriate for the next level, do interviews, and then it progresses from there. Sometimes there's multiple levels of interviews depending on the position and how strained the environment can be. For example, in Gaza, everybody goes through multiple interviews so that they understand just how literally hostile the environment is. You might be down to eating 1 or 2 meals per day versus 3 meals per day. You might not be able to leave, on your designated time. So we do a heightened level of onboarding in those cases to make sure people are comfortable. Everybody goes through a background check, everybody goes through a license check, and then we do meetings before deployment so people know what to pack, what to expect, what local customs and even the weather is like, and then all the safety issues are gone through. Here are your greatest risk factors. Here's how we're handling mitigation for those factors. Here's what to expect with your movements. Here's our professional policies that we expect everybody to abide by. And that gives people an additional opportunity to decide whether it's the right deployment for them.
Thank you, Andrea. And just to add on from how the process works on the H1 side in partnership with organizations like GRM or the other groups we work with. So we, regularly meet with them to ascertain what they're looking for in terms of where they're deploying, what specific passport holders, specialties, previous experience, et cetera, is needed for in general or for a specific deployment. And then as you fill out your H1 profile and fill out the applications for those opportunities you're interested in on our site, we cull through those so that we are sending a list over to GRM of folks who meet their general criteria, and then they can go over with a fine-tooth comb to make sure that that minimum criteria is met and that they have the appropriate candidates to deploy on a specific mission, deployment, et cetera. I'm wondering, Miles, are you seeing any questions we have not yet answered? Oh, I see Maggie said hi. Maggie from GRM has attended the meeting, and she just wants to emphasize that because GRM has small teams for deployment, she does not have opportunities for everyone to volunteer that has a desire to do so. And this is one of the benefits of H1 Connect, to provide opportunities for those people generally interested in international aid deployment, et cetera, to get them the resources they may need to prepare for those types of deployments, as well as all of those opportunities in one place. So you're not just on one NGO's listserv, you are seeing the opportunities available from all NGOs in the ecosystem, or some of them, so that you have more access to these opportunities. Thank you, Maggie. I'm just looking through any questions. And again, if anyone would like to ask a question live, feel free to raise your hand.
Katie, I wonder if you can speak a little bit more to the curriculum we're developing at H1 and the training and the resources, as well as the webinars in response to John's question on how they can prepare for service deployment?
Yeah, absolutely. So as Andrea and Maggie via the chat have both mentioned, deployments they're vital and they happen quickly, but they are rare for most NGOs that we work with. However, in the interim, H1 Connect provides resources to prepare you in advance of those. So you're gaining more access and understanding of the humanitarian aid space broadly if you don't have that prior experience. So we do that in a couple ways. With webinars like this, wherein we are talking to experts within the field about what that experience is like, how they're conducted, et cetera. In addition, we have medical advisors at institutions like the Harvard Humanitarian Institute, as well as Brigham and Women's, Harvard Medical School that recommend curriculum to us. So we do our best to provide free online courses relevant to global health, humanitarian aid, et cetera, that are available for you on the H1 Connect website. And Miles has dropped that link in the chat if you have not visited that site yet. In addition, some of the NGOs we work with have online courses, like there's for instance, a Be Safe course from the UN that they require volunteers complete prior to deployment. So in doing that ahead of time, we're able to demonstrate that if Save the Children, for instance, is in need of a volunteer type and you have that completed, you have the opportunity to upload those certificates onto the H1 Connect site so that we have that information connected to your H1 profile when we are going through candidates and looking at qualifications, et cetera. And then in addition, we hope to allow you to network with one another via the WhatsApp group, which is linked in the chat as well. So that's a place for global healthcare professionals to collaborate and share resources that have been helpful to them, courses that have been helpful to them, job opportunities, et cetera, that they have encountered through their existing network. So we encourage you to participate in that way as well. Miles, is there anything I missed?
No, I think that's it. It's great.
Cool. I'm just going through the chat one more time. While I do so, I guess, Andrea, Adam, any closing remarks, comments that you'd like communicated to this group of folks who are interested in the work you're doing and interested in participating in this type of work themselves?
I'd just say thanks for coming. Thanks for showing up and showing interest. It doesn't seem like it, but we are one big global community. We need to help each other. That's my focus. And I think that the work that H1 and GRM is doing is really the most important work. So thanks for considering, being a part of it. It's really great.
I would agree. There is so much need in the world. As a friend said, it's the best job in the world to be able to see something on the news and go do something about it and participate. But it's can also be really overwhelming because there's so much need, and sometimes you can't get to the place of need to respond and lend your skills to it. So we were really excited to partner with H1 and give our network an opportunity, as Maggie said, to meet their desire for wanting to help outside of just what we can offer.
Wonderful. Well, thank you both so much for joining today. And allowing people to hear your experience. And then we so appreciate being able to support an organization like GRM's, Andrea, and your work, Adam, in supporting their work as well. For those of you who joined, thank you so much again for joining. We do these webinars every month. They will vary in terms of focus and the type of guests that join, but they are always here as a resource for you. And with that note, I think we can end a few minutes early. We really, again, appreciate everyone joining. We know we have people joining from all over the globe, so there are some ungodly hours represented on this call, and we appreciate it. Again, thank you, Dr. Ackerman and Andrea, so much for joining.
Thanks, Katie.
Bye, everyone.